Hello and welcome to Wally's nursing videos. Today we will be discussing pediatric hematology. We will briefly discuss some of the topics and concepts related to the treatment of pediatric patients with common hematologic health problems. Iron deficiency anemia, hemophilia. Iron deficiency anemia. Iron deficiency anemia is a common condition characterized by a lack of sufficient iron in the body to produce healthy red blood cells. Iron is essential for the production of hemoglobin, which carries oxygen in the blood. When iron levels are low, the body cannot produce an adequate amount of hemoglobin, leading to symptoms such as fatigue, weakness, pale skin, shortness of breath, and dizziness. Causes of iron deficiency anemia include inadequate dietary intake of iron, blood loss, such as from heavy menstrual periods or gastrointestinal bleeding, pregnancy, and certain medical conditions. Treatment typically involves iron supplementation and addressing the underlying cause of the deficiency. Hemophilia. Hemophilia is a rare genetic disorder characterized by a deficiency or dysfunction of clotting factors in the blood, which impairs the blood's ability to clot properly. This leads to prolonged bleeding episodes, even from minor injuries, as the blood cannot form a stable clot to stop bleeding. Hemophilia is typically classified into two main types: hemophilia A, caused by a deficiency of clotting factor 8, and hemophilia B, caused by a deficiency of clotting factor 9. Symptoms of hemophilia include easy bruising, prolonged bleeding from cuts or injuries, joint pain and swelling due to bleeding into the joints, and, in severe cases, spontaneous bleeding. Treatment involves replacing the missing clotting factor through intravenous infusion of clotting factor concentrates, along with other supportive measures to manage bleeding episodes and prevent complications. Sickle cell disease. Sickle cell disease, SCD, is a genetic disorder of the red blood cells characterized by the presence of abnormal hemoglobin, known as hemoglobin S, HbS. This mutation causes the normally round and flexible red blood cells to become rigid and sickle-shaped under certain conditions, leading to various complications. Key points about sickle cell disease include: genetic basis. SCD is inherited in an autosomal recessive pattern, meaning that a child must inherit two abnormal hemoglobin genes, one from each parent, to develop the disease. Individuals with one abnormal gene are carriers, known as sickle cell trait carriers, and usually do not experience symptoms of the disease. Clinical features. The hallmark symptom of SCD is the sickling of red blood cells, which can cause episodes of severe pain, known as pain crises, as well as anemia, fatigue, jaundice, and organ damage. Complications may include acute chest syndrome, stroke, infections, and chronic organ damage. Management and treatment. Management of SCD focuses on preventing complications and managing symptoms. This includes medications such as hydroxyurea to increase fetal hemoglobin levels, pain management during crises, antibiotics to prevent infections, and blood transfusions in certain cases. Bone marrow or stem cell transplantation may be curative in some individuals. Complications and prognosis. SCD can lead to serious complications such as stroke, acute chest syndrome, organ damage, especially to the spleen, kidneys, and lungs, and increased susceptibility to infections. The severity of symptoms varies widely among individuals, with some experiencing milder forms of the disease and others facing more severe complications. Research and future directions. Ongoing research is focused on developing new treatments, including gene therapy and gene editing techniques, to correct the underlying genetic defect in SCD. Clinical trials are underway to explore the safety and efficacy of these innovative approaches. Pediatric versus adult. Hematologic system is intact and functional at birth. Blood cell production in the embryo begins at 8 weeks. Iron comes from the placenta before birth. Physiological anemia is normal after birth between 2 to 6 months. Assessment includes history of present illness, past medical history, family medical history. Physical exam findings include pallor, increased HR, easy bleeding or bruising, BP changes, splenomegaly, joint tenderness or swelling, conjunctiva color. Treatments include blood transfusions of PRBCS, whole blood, frozen plasma, platelets. Nursing considerations. Follow institution policies, double-check blood type and product label with a second nurse. Frequent vitals before, during, and after blood transfusion to detect adverse reactions. If adverse reaction is suspected, stop transfusion, run saline, reassess child, notify provider. may need to pre-treat reaction with diphenhydramine and/or acetaminophen before receiving blood products. Transfusions require a lot of hypervigilance in pediatrics, as children cannot tell you if their back hurts or if they feel shortness of breath. Pay attention to vital signs: tachycardia for pain, tachypnea for resp distress, assessment, increased WAB, increased fussiness, anemia, decrease in RBC mass and/or decrease in hemoglobin concentration. Most common hematologic abnormality in children can be congenital or acquired. Iron deficiency anemia, IDA, most common hematologic condition globally, and most common anemia in childhood, mostly affects young children, adolescent girls, and women. Etiology: body iron stores too low to support normal RBC production. This can be due to insufficient dietary intake of iron, impaired iron absorption, bleeding. Clinical presentation: low microcytic MCV, milkaholic, pica, napping longer than usual, fatigue, pallor, tachycardia, and systolic murmur with severe anemia, concave spooning of nails, cognitive delays. Iron deficiency anemia, IDA. Treatment: supplemental iron, ferrous sulfate. Limit cow's milk intake to 16 Oz day. Blood transfusion for severe symptomatic anemia. Follow your organization's blood transfusion policy. Nursing considerations: iron supplement administration, place liquid behind teeth. Ferrous sulfate can stain teeth. Education: iron-rich foods. Pair with vitamin C to aid in absorption, constipation, and dark stool. RT ferrous sulfate. Reasons to contact PCP: persistent signs of anemia. Nutrition consult. Hemophilia: X-linked recessive that results in deficiency of one of the coagulation factors, usually only males affected. Gene from carrier mothers to their sons. Factor VIII deficiency, hemophilia A. Factor IX deficiency, hemophilia B. Christmas disease. Factor C1 deficiency, hemophilia C. Presentation: newborn, prolonged bleeding after circumcision or heel stick. Early childhood, mouth bleeding, large bruises without trauma. Hemophilia A. Factor A8 is essential for activation of Factor X, required to convert prothrombin to thrombin. Complications include muscle bleeds, joint bleeds, oral bleeding, GI bleeds, hematuria, intracranial bleeds, development of inhibitors, development of antibodies to factor, 20-30% hemophilia A, lower incidence in hemophilia B. Hemophilia. Treatment include IV factor administration, prophylactically and prior to surgeries. Note that this can be very expensive. Limit activities with high risk for injury. Nursing considerations: education, reconstitution, administration, and a safety plan. Sickle cell disease, SCD, is an autosomal recessive trait prevalent primarily among African American, Southeast Asian, and Middle Eastern individuals, affecting approximately 1 million people worldwide. In African American populations, it manifests in 1 out of every 365 births, while in Hispanic American births, the occurrence is approximately 1 in every 16,300. Diagnosis typically involves newborn screening, genetic testing, sickle turbidity test, and hemoglobin electrophoresis. Hemoglobin development progresses from conception to 42 weeks of life. During fetal development, primarily fetal hemoglobin, HGBF, is present, characterized by larger size, resulting in increased mean corpuscular volume MCV and higher affinity for oxygen. Between 36 weeks gestation and 6 months of age, there is an increasing production of adult hemoglobin, HGBA, with HGBF constituting approximately 65-95% in newborns and primarily transitioning to HGBA by 6 months of age. Fetal hemoglobin, HGBF, does not sickle. Sickled cells clump, blood become more viscous, no blood flow result in vaso-occlusive process. Vaso-occlusive process. Hemoglobin S, HGBS, arises from the substitution of a single amino acid, glutamine, valine. Unlike the typical 90-120-day lifespan of HGBA, HGBS has a shorter lifespan of around 15 days, leading to increased reticulocyte count. Under conditions of stress or trauma such as infection, fever, acidosis, dehydration, physical exertion, excessive cold exposure, or hypoxia, HGBS polymerizes, forming characteristic sickled cells that are sticky and inflexible. This polymerization leads to intravascular hemolytic anemia, causing occlusion of microcirculation, ischemia, and subsequent chronic organ damage. Or in simpler terms, hemoglobin S, HGBS, is a type of protein in our blood that is different from the usual type, called HGBA. It's caused by a tiny change in its structure, making it more fragile. While HGBA can live for about 3 to 4 months, HGBS lasts only about 2 weeks. When the body undergoes stress or injury like infections or lack of oxygen, the HGBS molecules can stick together, forming sickle-shaped cells. These cells are sticky and stiff, which can block tiny blood vessels, causing problems like anemia, not enough healthy red blood cells, pain, and damage to organs over time. Vaso-occlusive crisis, VOC, occurs when triggers, such as the presence of hemoglobin S, HGBS, cause red blood cells, RBCs, to transform from pliable discs to rigid crescent or sickle-shaped cells. These sickled cells become obstructed in smaller capillaries and venules, leading to local tissue hypoxia, ischemia, inflammation, and ultimately organ infarction. While usually reversible, repeated insults can result in permanent sickling of cells. Diagnostics typically reveal worsened anemia from baseline, elevated reticulocyte levels, and hyperbilirubinemia. Treatment of VOC involves hydration, although caution is necessary in patients with kidney damage or cardiac failure. Oxygen therapy is administered along with pain medication such as intravenous narcotics, either scheduled around the clock or through patient-controlled analgesia, PCA. Dosage is weight-based but may require adjustment due to high tolerance. Additional measures include intravenous ketorolac or oral ibuprofen, limited to a maximum of 5 days, oral acetaminophen, and the application of heat packs, avoiding the use of ice. Dactylitis. Symmetric swelling hands and feet in an infant or toddler with SCD-8's emergency. A septic infarction occurring in metatarsals and metacarpals. During vaso-occlusive crisis, VOC, nursing considerations involve conducting a thorough physical assessment, including neurological and peripheral vascular assessments encompassing pulses, capillary refill, and sensation, as well as respiratory evaluation. Pain assessment is crucial, both before and after administering pain medication, utilizing appropriate pain scales. Measures such as incentive spirometry, employing methods like pinwheels, bubbles, and whistles, aid in preventing acute chest syndrome, ACS. Monitoring baseline laboratory values, typically lower than normal, especially hemoglobin levels ranging from 7 to 10, is essential. Collaborative care involving child life specialists, social work consultation, physical and occupational therapy, child psychiatry, and art therapy supports holistic patient management. Education and advocacy play pivotal roles. ACS carries significant risks, including a 3% mortality rate and an 11% incidence of neurological events, underscoring the importance of early detection and treatment. Optimal pain crisis management, heightened vigilance, and interventions like incentive spirometry, hydroxyurea, and chronic transfusions are key. Recognizing symptoms such as cough, chest pain, audible wheezing or rales, fever, and shortness of breath prompts timely intervention. Incentive spirometry. This is a breathing exercise tool used to help improve lung function after surgery or to prevent lung complications. It involves taking deep breaths through a device that measures the volume of air inhaled, encouraging deeper breathing and helping to prevent lung problems like pneumonia or atelectasis, collapsed lung tissue. Acute chest syndrome, ACS. ACS is a serious complication of sickle cell disease where there is inflammation and/or infection in the lung. It can cause chest pain, difficulty breathing, and low oxygen levels. ACS is often triggered by infection, but can also occur due to other factors like pain crises or lung injury. Splenic sequestration and functional asplenia. In sickle cell disease, the spleen can become enlarged due to trapped sickled red blood cells, leading to splenic sequestration crisis. This can cause sudden enlargement of the spleen, leading to low blood pressure and anemia. Over time, repeated sequestration crises can result in functional asplenia, where the spleen becomes damaged and less effective at filtering the blood and fighting infections. This increases the risk of severe infections, particularly from encapsulated bacteria like Streptococcus pneumoniae. Splenic sequestration, a condition characterized by vaso-occlusion leading to the pooling of red blood cells within the spleen. This can be life-threatening due to the potential development of hypovolemic shock. Clinically, patients may present with left upper quadrant, LUQ, pain, fullness, and tenderness, alongside a significant drop in hemoglobin levels by more than 2 grams per deciliter from their baseline. Reticulocytosis, indicating an increase in immature red blood cells, may also be observed, along with splenomegaly. Treatment involves rapid red blood cell transfusion, with careful monitoring for signs of fluid overload, warranting prompt notification of the medical team for appropriate rate adjustments. Moving on to functional asplenia, this condition results from repeated insults to the spleen, predisposing individuals to bacterial infections from encapsulated organisms. Common pathogens include Streptococcus pneumoniae, Haemophilus influenzae, Neisseria meningitis, Klebsiella pneumoniae, Group B Streptococci, and Escherichia coli. SCD patients with functional asplenia face an increased risk of bacteremia, sepsis, meningitis, and osteomyelitis, particularly given the presence of central lines in some cases. However, mortality rates have decreased due to preventive measures such as penicillin prophylaxis and vaccination against encapsulated organisms through the conjugate pneumococcal vaccine and the Haemophilus influenzae type B (HIB) vaccine. Chronic management strategies for sickle cell disease (SCD), focusing on 3 key approaches: hydroxyurea, glutamate, and chronic red blood cell (RBC) exchange transfusions. Let's start with hydroxyurea, also known as Hydrea. This medication works by increasing the percentage of fetal hemoglobin, HGBF, which does not sickle in response to stressors, thereby reducing sickling episodes. However, it's essential to be aware of potential side effects such as leukopenia, reduced white blood cell count, myelosuppression, reduced absolute neutrophil count, nausea, and vomiting. Monitoring for increased mean corpuscular volume, MCV, can help determine adherence to treatment. Next, we have glutamate, marketed under the name Endari. This compound acts as an antioxidant, mitigating sickling episodes by reducing oxidative stress. It achieves this by decreasing the glutamine to valine substitution that occurs during the formation of hemoglobin S, HGBS. It's worth noting that glutamate is available in powder form, and its taste can impact patient adherence. Lastly, chronic red blood cell exchange transfusions play a vital role in managing SCD. By regularly replacing sickled red blood cells with healthy donor cells, these transfusions reduce the risk of complications such as hyperviscosity, which can occur with simple blood transfusions. Additionally, they significantly decrease the risk of stroke, a severe complication of SCD. Curative, allogeneic hematopoietic stem cell transplant, HSCT, targeted gene therapy. Allogeneic hematopoietic stem cell transplant, HSCT. This is a medical procedure where healthy stem cells from a donor, typically a close genetic match such as a sibling, are transferred into a patient with a disease affecting the blood or bone marrow, such as leukemia, lymphoma, or sickle cell disease. The goal is for the transplanted stem cells to replace the patient's unhealthy blood-forming cells with healthy ones, effectively resetting the immune system and blood cell production. However, this procedure carries risks such as rejection of the donor cells or graft versus host disease, where the donor cells attack the recipient's tissues. Targeted gene therapy. Targeted gene therapy involves the delivery of genetic material into specific cells of a patient to correct or replace defective genes that cause disease. Unlike traditional gene therapy approaches, which may involve the introduction of genes into cells randomly, targeted gene therapy aims to precisely target the affected cells and deliver the therapeutic gene with high specificity. This can be achieved using various techniques such as viral vectors or gene editing tools like CRISPR-Cas9. Targeted gene therapy holds promise for treating a wide range of genetic disorders, including inherited blood disorders like sickle cell anemia, by directly addressing the underlying genetic cause of the disease. Sickle cell disease teaching. Seek emergency medical attention if child is pale and listless, abdominal pain, limp or swollen joints, cough, sob, chest pain, increasing fatigue, fever, unusual headache, loss of sensation, sudden weakness, sudden vision change, painful erection that won't go down, priapism. In managing sickle cell disease, various medical interventions may be necessary depending on the specific complications. For instance, if gallstones develop, a cholecystectomy may be required. To prevent life-threatening occurrences of splenic sequestration, splenectomy might be performed. Hydroxyurea is a medication that can boost the levels of fetal hemoglobin, thus reducing vaso-occlusive events. L-glutamine, either alone or combined with hydroxyurea, has been found to decrease the frequency of painful vaso-occlusive episodes. While blood transfusions are not typically given routinely to children with sickle cell disease, they are recommended in cases of prolonged or widespread pain, aplastic crisis, or splenic sequestration. Partial exchange transfusion may be employed to rapidly reduce the levels of HGBSS in emergencies such as stroke or acute chest syndrome. Hematopoietic stem cell transplantation, though a potential treatment option, is usually reserved for children with an identical HLA-matched sibling due to high risks of death and graft versus host disease. Sickle cell disease summary. Overall, sickle cell disease is a complex disorder that requires comprehensive management and ongoing medical care to improve outcomes and quality of life for affected individuals. Early detection through newborn screening programs and advances in treatment offer hope for better outcomes and a brighter future for those living with SCD.